and the floor is yours.
Thank you, Gallus. And also, Jim, thank you for a very thought-provoking presentation. I now have a longer book list than I will be able to get through, and a lot of things to ponder, particularly like your challenge of moving beyond the field of specialism. So we have ahead of us 3 very interesting presentations, and just a quick reminder, we need to manage our time very tightly, so each presenter will have 15 minutes to present, and then we'll have 5 minutes for questions. Please continue to use your chat feature or raise your hand as you think of questions. So our first presentation is from Rebecca Foster, who is from Scotland and is presenting on why would we not want to keep everyone safe. Rebecca? I think you're on mute.
I am, yeah, sorry, I'm just going to get the slides up, hopefully. Didn't want to do it too quickly, sorry. This is always the longest time between trying to get your slides up. There we go. So hopefully this is going to work. Can people hear me okay?
We can hear you fine.
Great, thank you.
But there's no screen sharing yet.
No, it looks, I can see it on my screen, so it's just taking its time. Loading very slowly. So just about doing that, I'll just say, so I'm Rebecca. I'm, as you said, I'm from Scotland, and I'm a lecturer in criminology at Edinburgh and Napier University. And this is a new post for me as I'm now in week 3. Before that, I worked at Stirling University, where I was a research fellow, and that's where I conducted this study and I led the study. Okay, so I can see the presentation on my screen. Great.
So can we. Yeah.
Is it big enough? Yeah. Is it looking?
It's
okay.
Perfect.
Perfect. Okay, that's great. Thank you. So here we go. The next bit is switching slides. Okay, so this is just quickly just our very varied study team, range of expertise, and we're based largely in Scotland, but also included people based in England. As you can see, a range of affiliations there, and we worked in close partnership with a research consultancy and Transform Drugs Policy Foundation, so a third sector organisation. So I'm imagining most people here are familiar with what a drug consumption room is, but there can be differences in terminology, so I just want to make sure everyone's on the same page. So what do I mean by drug consumption room? Well, I mean legally sanctioned, low threshold space which is safe and hygienic, where people who use drugs can go and take their pre-obtained drugs. So importantly, they're not being provided with drugs in that service, although some models might combine with medication-assisted treatment, for example. As I said, there's different terminology used. Some refer to overdose prevention sites, some supervised injection sites, and so on, but it's all generally getting to the same thing. And there are about 200 DCRs operating internationally. There are public health and harm reduction intervention that aim to keep people safe, basically reducing the risk of overdose and death and other harms caused by drug use, particularly injecting drug use. So, for example, aims to reduce difficulties caused by sharing needles and reduce incidences of infection at injection sites, and also reduce things like drug-related litter. And it has they tend to have a broader aim of also better linking people who use drugs to other services, so enhancing social integration. What they look like will vary from place to place. The models vary. Some are very clinical models, while others are kind of peer-led, community-based initiatives, and of course some fall in the middle. In terms of the evidence, there's a high willingness of people who use drugs to use these services. A lot of evidence does come from Sydney and Vancouver, and that relates to the fact that there's well-established sites there. But the evidence in general shows really positively that drug consumption rooms do indeed make people safer, reducing incidences, for example, of overdose, reducing incidences of admission to hospital, and so on. And it's really important to point out that to date, there's been no recorded overdose death in a DCR anywhere in the world. That's pretty powerful stuff. But of course, as researchers, we always say more research is needed, and more research is indeed needed, including from kind of internationally, not just mainly, not just from Australia and Vancouver. So I'm just also really trying to keep to time here, so I'm whizzing through this. So the Scottish context of the study, we've got quite a strong contingent from Scotland in this conference, and you're getting a different insight into different aspects, but I don't think we've covered this. So Scotland's got a devolved administration, so Holyrood controls health and justice policy, but perhaps quite curiously, drug legislation is reserved to the UK government. And aspects of implementing a DCR directly contravene the kind of overriding piece of legislation in this area, which is the Misuse of Drugs Act 1971. Now, while in Scotland over the past 10 years or so, there's been increased calls to implement a DCR in Scotland, the UK government continues to reject this proposal, citing concerns that a DCR enables continued drug use and so on. So that's kind of where we are. I want to say that the challenges to do with implementation in Scotland are not unique to the legal issues, and obviously challenges of implementation a DCR anywhere in the world are found anywhere in the world. They're not unique to Scotland, but it's really important to emphasise that these kind of legal, political complexities in Scotland are representing a significant barrier to implementation. Okay, and then lastly, kind of where our study fits in, there's developing evidence base, as I mentioned, but there's two key groups who are still overlooked, and these are family members of people who use drugs, of course, what I'm going to focus on today and what we're interested in here, especially, but also professionals who have workforce responsibilities that are relevant to implementation. So, for example, what do the police think about drug consumption rooms? What implications are there for social work, and so on? Obviously, taking aside the important issue of listening to first-hand lived experience accounts, it's also important that to get buy-in for any implementation or service, and that the evidence shows that that's a relationship with listen to first-hand accounts. They can tip the balance in favour of implementing a new intervention or service. Okay, and there are research questions here, which I'll just paraphrase. Essentially, we're looking at what do these two groups think of drug consumption rooms and how have they arrived at that conclusion? So what factors are shaping these perspectives, and what do they see as being the potential facilitators and barriers to implementation? Okay, so this was another one of the Drug Death Task Force funded studies in Scotland. There were 10 funded in 2020. Professor Whitaker discussed one yesterday, and this was another one. It ran from September 2020 to June 21. And we interviewed two groups of people, the two groups I mentioned, and I'm focusing today on the family members, the 13 family members we interviewed. Of course, we wanted to interview more than that, but the pandemic really, we think, affected our sample. So although we only interviewed 13, we did have really rich data, and we had an inclusive definition of family, so all types of family member were invited to take part. And in the end, our sample included partners, parents and cousins. The majority were mothers, majority were women, 11 of the 13 were women, a lot of these were mothers, but we did have good geographic coverage across Scotland. It wasn't limited to the Central Belt, so we included the north and the south of Scotland. And although we aimed originally to include family members who loved ones were currently using drugs to capture the current landscape, in the end we broadened our inclusion criteria to include people whose family members identified as being in recovery, and also very sadly we included people who had lost a loved one to drug-related death, and obviously we secured ethical approval to make those changes. I'm not going to talk about this, but we did also interview 26 decision makers to get their perspectives. Okay, and of course, all of our interviews were conducted online and transcribed verbatim, and then we analysed the findings. So let's get on to the findings, which I know is often the most interesting bit of these presentations. So what we found, family members had really varying levels of knowledge. Some had very detailed knowledge of DCRs and different models in the world. Some were active campaigners, but others had very, very little knowledge at all of DCRs. It's important to point out that in Scotland, some people may be aware, at the time of interviews, an activist, Peter Cricant, established an unsanctioned overdose prevention facility in the form of a van in Glasgow, and this had really got a lot of media coverage, and this had kind of raised the profile of DCRs in Scotland, and actually even among the family members who didn't know very much about DCRs, they recalled this example and talked about this in interviews. Often family members described how listening to other family members' kind of views on drug consumption rooms helped persuade them on the value of drug consumption rooms. So here's one of the quotations, which I'll just kind of paraphrase. So it was like a light bulb moment, and the DCR, the idea of a DCR was just one, of many things I thought, oh my golly, I can't believe we don't do this as a humane society. It was literally just going through reading about it and immediately thinking, why on earth are we not doing this? So DCRs were generally viewed really positively overall. And although some had a very slight reservation about DCRs and kind of enabling continued drug use, overall, these reservations were outweighed by a perception of the perceived benefits of DCRs. As you'd expect, they saw DCRs as an important harm reduction tool, and also that broader aim of helping to connect people who use drugs to other services. Many family members are counted numerous examples of kind of negative interactions with healthcare services their loved ones had, if at all, and that of course will be familiar to people in the audience, the challenges there. So here, kind of family member described her partner's experience of this. So he tried to get help, he reached out to someone through the NHS, that's our National Health Service, but it just wasn't facilitated very well. In the end, he just continued what he was doing because he couldn't get the help they needed. So I feel that a DCR would help those people. Another key finding with stigma, and again, that will, I'm sure, not come as a surprise to the audience, stigma was fundamental to the experience of people who use drugs. Family members conceptualise it as having an impact at both an individual, a micro level, and a macro level. An individual level, it meant people who use drugs just were disinclined to access services. At a macro level, implementation of policies to help people use drugs was not prioritised. So DCRs were not implemented in Scotland because people who use drugs were not seen as a priority concern. So it's perceived to be a major barrier to DCR implementation, but there was a kind of a twofold bit here. So if DCRs were able to be introduced, they felt that in doing so, this could help address the stigma because it would help communicate to all that actually people who use drugs were worthy of care and attention. And so that this person here kind of talks about that. So I think it just symbolically shows that we care as a society. It's one step to showing that we will treat people who are in pain, and that's generally what it is. And we'd hope that Scotland could lead the way in this, and it would send a signal to the rest of the UK about how things could be done in a more humane society. Okay, next bit is kind of terminology, and I mentioned already that there's different terminology used, and actually a lot of interviews talked about this in quite a bit of detail. So, for example, some felt consumption room focused too much on the consuming of drugs. Some felt that supervised injection site, the supervised dimension, communicated in some way that the person was problematic, they had to be supervised, and this wouldn't be ideal. Others felt overdose prevention service would be better because it would be more focused on what the role of a DCR was. But the key point here across all this discussion was that the language and terminology communicate something, and it can either increase or reduce the stigma. And although we didn't focus on the intricacies of the model of a DCR, family members emphasised the importance of a DCR being a really safe and welcoming space. So I'm trying to keep to time, so I'm hoping I'm on track for that. So study limitations and conclusions. So yeah, we know the small sample size of 13 was less than we aimed for, but nevertheless we did have a really rich data set, and people were really open with their experiences, and we really value their participation, particularly in the context of the COVID-19 pandemic. The sample showed the strong support for implementation among family members, even where they recognise concerns, even where they recognise the challenges. DCRs were viewed as potentially contributing to a shift in attitudes, a shift from criminalisation and punishment to care, compassion, and a more public health approach. And they were well aware of the challenges of implementation. They didn't see them as being small by any stretch, but they also called for these challenges to be ultimately overcome. In the Scotland's drug deaths crisis, where Scotland has a highest drug-related death rate in Europe, actions needed quickly, and so the recommendation from this study would be to proceed to piloting DCRs without delay. We have published 2 papers so far from the study, one focusing on the family member findings and one focusing on the decision maker findings, and these are both open access and provided the links there. I'd like to thank you very much for listening, and hopefully you've been able to keep track, especially my quick pace. And obviously you can see we're funded by the Drug Deaths Task Force, and we would like to acknowledge our participants and our experts by experience group and our research advisory group whose contributions really positively impacted this study. Thank you very much. I'll stop sharing my screen now.
Rebecca, thank you very much for a very interesting presentation. It really underscores the importance and value of education. We have one question from Steve Stoughton. Any information about impact on violence or crime connected to the people using these rooms?
Yeah, sorry, I was skipping through the evidence, but there is some evidence on that. More is needed, but the idea is that it does reduce crime and all kind of obvious crime, and then related crime to do with consuming drugs like theft, for example. So it's a positive impact, and another reason why implementation would be a good thing. This didn't come as much up in the family member interviews, but decision maker interviews, particularly the police, for example, talked about an anticipated benefit of this. Thank you. It's a good question.
I asked her because I just wondered how family members perceive that as well, because when I've lived in Australia before, and when they were talking about it, not just in Sydney but other places, there was a lot of concern about, is it going to cause more crime in and around the place? And I've just never really heard whether that's supported or not supported. So yeah, thanks.
Yeah, it's more the opposite.
I see that Ed Sipler has a question. Ed?
Yeah, real practical one. Really good presentation, Rebecca. Really thought-provoking. Realistically, how far off are you from piloting drug consumption rooms in Scotland? Because I know in Northern Ireland we're only a short little boat ride away, and we'll be looking very carefully at what you're doing. But we're lucky to get shopping on a Sunday. Drug consumption rooms might be a bit far for us. But yeah, how far off are you?
Thank you. Yeah, so I'm not sadly in the know about what's going on, but the chat I hear is that actually there is chat about piloting an approach, but I'm not sure how they're doing it with the whole Lord Advocate issue. But I think there seems to be what's happening, but I'm not sure when. And as you say, it's like could well be quite a while away. So I'm kind of watching with interest and hoping to get a bit more intel.
Thank you.
I have a question, which kind of piggybacks on Ed's around how this is being taken forward. Are you anticipating any more research or furthering sort of the education initiative in any way?
So I think one thing is, so I mentioned the funders here is the Drug Death Task Force, essentially the Scottish Government, and they're really happy with this. So they really want to go, and actually, as far as they're concerned, they don't need to do any more research. They're happy to go with this. It's just the whole legal landscape thing and whether or not people are actually going to be prosecuted if they implement it. But yeah, one of the things that I didn't talk about a huge amount, but certainly if they do implement it, our recommendation is that it would be coupled with an education campaign to get people on board, with family member perspectives being a key part of that. But unfortunately, I'm not kind of privy to how that's going to be about, but that's one of the recommendations, and the task force agrees that would be needed, particularly with public perceptions on these issues.
Right. And I see a question from Richard.
I know you don't have much time, so I'll be brief. I'm interested in the family members' perspectives, and I'm interested in the fact that although they could see potential concerns, they thought it might be for the best. But I'm also just interested in how much variability there was, as it strikes me that this whole issue about how family members cope with the use and of their loved one is a really important one, and there must have been some concern that by normalizing it, by allowing it, by the authorities allowing it, that might somehow exacerbate the problems. Did that come up much?
It definitely did, and the paper I've referenced there talks about this in more detail, and that's really important. We don't trivialize that. There definitely was concern because they just want people to stop. They're relevant to stop using drugs. So anything that does that, but then they also recognised that the most important thing was they were safe, and they weren't quite ready to do that. So they kind of conceptualise it as a stepping stone to initially keep them safe, and then going to the service, they might link up with other services, and that would be kind of a journey of recovery. But yeah, it's important not to trivialize those concerns were there, particularly among family members who kind of adopted the more abstinence-based approach. Yeah, thank you. It's a good question.
Thank you, Rebecca. But very good, very interesting and fast presentation.
Hopefully people whose first language is not English, and then my Scottish accent as well. So yeah, maybe need a translator. Thanks very much.
Rebecca, you did a phenomenal job in time management. Thank you very much. And I see one last just comment from Maxine Lacey, a very interesting and thought-provoking presentation. And she and we all wish you best of luck with opening the DCRs in Scotland.
Thanks very much.
All right, so we're going to move on to our next presentation. There's a slight change in sequence. We'll next hear from Dr. Florian Meulewaeter from Ghent University in Belgium. And you can see her slides already up on the screens. I'm going to move us along if I could to make sure that our third presenter has space, but an absolutely interesting presentation. Thank you so much.
Thank you very much.
And I see that, Ed, you did have a question. If you could type it into the chat so that we can capture it for later, for follow-up.
I don't have chat, but Florian, I really enjoyed that. I'm going to drop you an email with my question because I'd like to get a conversation with it about it. Really good, though. Excellent stuff.
Thank you very much. Thank you. Thank you.
All right. Thank you. All right. Our last presentation is by Sahar from Pakistan. And she is recently, we want to congratulate her on her new position with the Capital University of Science and Technology in Islamabad. We are going to listen to a recorded presentation, and then we believe Namood will be able to join us at the end of the presentation for questions.
Yes, I'll try to share the video. I'm afraid the audio, the original audio on this video is really low, but we'll see what we can do.
Thank you, Sahar.
Sure. Let me know if this doesn't work.
I am very thankful to the organizers for giving me the opportunity to present in the pre-recorded version of my oral presentation. I am Sahar from National Institute of Psychology, Qaid-e-Azam University, Islamabad, Pakistan, and my co-author is Dr. Iram Naqvi, who is also my research supervisor for my PhD thesis work. The presentation I will be giving today is on attitude towards substance use recovery among the caregivers of substance users, indigenous perspective from Pakistan. This is a part of my PhD research work. So getting on to the basic introduction, caregivers of substance user are the person who provide primary care to them, assist in managing their psychological as well as physical, emotional and social health, and monitor the symptoms, either they are relapse symptoms during their recovery processes or the other symptoms they are experiencing. Also, the caregivers attend to the needs of substance user and improve their treatment adherence. Now, if we talk about impact of caregiving, the research evidences support a decline in the physical health, psychological health, poor social well-being, and the decrease in the overall emotional well-being of the caregivers due to the caregiving they are providing to the substance using loved ones. So these all factors contribute in creating a burden and adverse effect on the caregivers. Now if we talk about what is prevailing attitude towards substance users recovery, the literature support many diverse types of attitudes prevailing as per the experiences of caregivers of substance users. They are unrealistic expectations from substance users because of maybe unaware of substance use and the recovery processes that are part of the substance use, and getting rid of the substance use their loved one is having substance use problem is a very diverse and comprised of different factors that adversely impact substance user as well as their family members, who we also know term as the affected family members. Then the research also demonstrate that hopelessness and different anxiety, fears are also associated with recovery of their loved ones. Then some positive attitudes also exist, such as the caregivers realize the relational nature of recovery, that both they themselves and their substance using loved one would play an important role in recovery, and it is a collaborative effort which could help in reducing the substance use among them. Then the disease model and the free will model of substance use also give us the information about recovery and the attitudes or beliefs that are associated to it. According to disease model, the recovery is basically more related to the treatment processes, because the disease model considers substance use as a disease, whereas the free will model emphasizes the role of individuals' own free will and the power of control over the substance use. So these are some attitudes toward substance use recovery that are prevailing as per the literature. Now the rationale of the study is that approximately 91 million of world population comprised of caregivers have experienced adverse effect due to the substance use of their relative, and these adverse impact is also evident from Pakistan's literature. However, none of the study yet has explored the attitudes and the impact in depth. The literature also provides support that negative attitude toward recovery could result in high stress, which is also an important contributor toward the adverse impact caregivers are facing. So the present study aims to explore the attitudes that prevail for the substance user recovery, as they are important in contributing toward the adverse impact they might be facing. Now if we talk about methodology, the method section comprised of design, which we followed is the interpretative phenomenological approach, IPA, because the every caregiver is having different context and different social placing, different social role. So from the individualistic point of view, the study of attitudes is very important. So we use IPA as a research design process. Objectives of our study is that to explore attitudes towards substance use recovery from indigenous perspective of Pakistan. Then we will talking about sample. The total sample of the study comprised of 12 caregivers of substance users, among which 3 are parents, 2 are spouses, 3 are siblings, 1 is the offspring of a substance using person, and 3 are the close friends. All the individuals who were interviewed identified themselves as the primary caregiver of substance using individual. The inclusion criteria was that caregivers must be at least 20-year-old and involved in the caregiving role for at least the time period of 2 years. The main demographic characteristic of caregivers show that majority were part of a joint family system and are married with the education level of education level, at least graduation level. The area of residence was very diverse. For the sample, we collected information from different areas of Punjab, Islamabad, and some sample is also approached from areas like Mardan, Sheikhupura and Gujranwala. So we have a diverse diverse population of our sample which we interviewed, and the saturation of information was achieved during the interviews of these 12 participants. The procedure was that a sample was approached through rehabilitation centers and different substance use control organizations which are having a positive role in recovery of these substance users, and rapport was also built with the participants before interview. They were also given the consent of recording the information they will be providing, and the anonymity and confidentiality of that information was also ensured to them. The psychological safety of caregivers was also of very important in these interviews because of the sensitive nature of topic that we are exploring related to the substance use, which is already considered as somehow a taboo for in the society we are living. So the psychological safety of caregivers was also considered during interviews, and the debriefing session was also conducted. Now getting on to the research section, the main themes were generated based on the information we obtained. So according to the ABC model of attitude, the attitude mostly comprised of affect portion or the feelings associated, the beliefs or thought processes, and the associated behaviors. So the first theme of our results we have obtained is meaning of recovery. For the theme of meaning of recovery, we have obtained two major categories of this theme. The first is stay away from drugs forever, and the decrease in frequency of drug use. This is considered as recovery from the perspective of caregivers who has a loved one with substance use problem. The next theme is about beliefs the caregivers have about recovery of drug and substance user from substance use, and the main categories we obtain as treatment as a only process, realization of substance user as important factor, and the third was that relapse is inevitable and cannot be avoided and always is a part of recovery. Then some caregivers are also of the view that recovery is a continuous process and complete recovery is a very difficult thing. Then the next theme is about ways of recovery from substance use. The main categories under this theme are constant monitoring, treatment, distract oneself at the time of urge and get involved in some other behavior, for example some positive hobby or constructive approach that could distract the person, maintain a proper routine which could be helpful for the substance user and caregiver could play an important role in it. Then the religious orientation or getting more involved in the religious activities is also highlighted as a main point, and the social support and care for the substance user was also highlighted by the caregivers as an important way of recovery. Then there are some constraints also associated to the recovery which are informed by the caregivers. These are opportunity to use the drug, financial constraints for the treatment, and absence of willingness of substance user, absence of drug control policy here in Pakistan, the hopelessness which is involved associated with recovery, the strong peer influence to use substances during parties or gatherings, and the stigma associated environment of rehabilitation center was also highlighted as not so much comforting and positive for the change in substance user. Then the absence of willpower was also highlighted. Lack of caregiver ability to constantly monitor the substance using loved one was also informed by the caregivers. Early onset of drug addiction and the medicine used for treatment are also highlighted as main points. The caregivers informed that the detoxification medicines that rehabilitation often use are addictive on their own. So this was also a major constraint during the recovery process. So we can conclude that there are different attitudes and different component of attitudes and variable things associated with the recovery of substance user as per the caregivers or their affected family members. So the information achieved could be used by the future researchers to develop an indigenous scale to assess those attitudes that prevail and different attitudes, positive as well as negative, and check their role with the recovery of substance user and with the impact the caregivers are facing, the caregiving roles, the caregiving burdens, the impact on them, the psychological, social well-being, emotional well-being, all is impacted, as I also mentioned in the introduction part. So the an indigenous scale would be very helpful in this regard. That's all from my side. Thank you for the active listening, and the questions are always welcome from your side. And also, I would be very helpful if you provide some positive suggestions for the improvement of my work.
Thank you very much. Is Namood, have you been able to join us?
Yes, ma'am. Hello, I have joined now. Thank you so much.
Oh, that's wonderful. And congratulations on your new position.
Hello.
I want to thank you for a very interesting presentation. I was thinking as I was listening to it, it's so illustrative of the complexity and variety of attitudes on the part of caregivers. Were there any surprises for you in your findings?
Thank you so much, ma'am. Thank you so much. Are there any questions for me, because I have joined so late, so I am unable to see the chat section if there are any questions related to my presentation?
Namood, this is Eileen, and my question is: were there any surprises for you in your findings? I'm not sure you can hear us.
Yes, I can hear you now. Am I audible to you?
Yes, you're very audible. You are very audible.
Thank you so much. Are there any questions?
Yeah, Eileen has asked you a question now twice, so I will have a go as well. Her question is, did any of your findings come as a surprise?
Yes, the associated emotional aggression as well as the hidden fears that the caregivers expressed during the interviews was very surprising for me, and also a little overwhelming, because at that time I also have to be very composed myself. And then the debriefing sessions were also very important in that regard, because they get emotionally a little disturbed. So in the almost half hour and a half hour to 1 hour of the interview, almost 15 to 20 or at times 30-40 minutes were contributed to the debriefing sessions.
I'm not
Right,
surprised. This is Richard here. I'm not surprised that that happened. I imagine for many of these family members, it must have been one of the first times that they had talked to somebody about what it was like being a caregiver.
Yes, absolutely. Because I think that in the rehabilitation centers here especially, we don't have proper guidance as well as facilitation for the caregivers, which is very essential because they are also facing very problematic situations.
Absolutely. That's, as you know, that's why we have developed AFINet, because we know that family members and caregivers are often ignored. And I wonder, my understanding, my expectation is that that might be even worse in Pakistan. I just wonder how the way that substance use is understood in Pakistan, and maybe any religious influences on that. I wonder how they
The substance use has
carry on.
There is a very high stigma for the substance using person as well as for the family, because in some cases we also have observed that the substance users using behavior of the family member is attributed as a fault of negligence, maybe by the upbringing the parents have done. So the family stigma as well as the stigma substance using persons are facing is very high here.
All right. Seeing no other questions, Namood, I want to thank you very much for a very interesting presentation, and turn the chair over to you, Richard.
Okay. So